Thank you very much, Dr. Levine, and thank you to Dendrite and DNS for giving me an opportunity, and thanks, Jens, for arranging it. Welcome, everyone. Good evening. So the topic of today's webinar is predictable treatment planning for single tooth implant restorations. So let's get going with that. So it's a very broad topic. Typically, it's very difficult to cover all these things in 45 minutes, but I will try to give you a concise overview about single tooth implant restoration. It's a very baseline lecture for dentists who are starting to place implant and restore implants, or who are out of dental school, or who are looking into some guided surgeries. So I will be talking about that. As with all my lectures, first thing is a disclaimer that I don't have any financial conflict to disclose. I'm a full-time employee of my new prosthodontics and implant center. I'm not offering any medical opinions or promoting any products here, and I'm just wanted to let everybody know. I'm located in Green Bay, as you mentioned. I'm fortunate to be in the Packerland area and running my practice. So that's my location where I'm located. So key learning objective of today's webinar. Our aim is to understand the clinical and radiographic evaluation for single implant cases, how to apply prosthetically driven principles to implant positioning and restoration design, identify biological, functional, and aesthetic risk factor during implant treatment planning, select appropriate implant and restorative options for predictable outcomes, collaborate effectively with surgical and laboratory team to optimize results. So when we start, this is a picture I can put in front of which one is an implant crown. Looking at it, if it's a live webinar, I talk to people, but since we are on a webinar, so looking at it, number 9 is an implant crown. When we're looking at it, our aim is to achieve as optimal result as possible. It depends on a lot of factors, which some are medical factor, surgical factor, and restorative factor. Of course, labs plays an important role in fabricating these appliances. So we have to put all this together in a way that we can provide the best and the optimal results to our patient. While I was working on this presentation, I came across, since this is the time we live in, with everything is controlled through AI, this is one of a position statement I published for American College of Prosthodontics on diagnostic imaging and treatment planning, surgical and prosthetic aspect of implant dentistry. So while I was working on it, I was trying to search for something, and I came across, it was just quoting something which was out of my article, which I wrote 6-7 years ago. So it's funny, so I thought maybe I should put it over there. So if you get a chance, go to ACP position statements and you will get some information about it. I put the link in the webinar, and then we will move to the next slide. So let's start with treatment planning. So when we talk about treatment planning for implant cases, whether it's a single or multiple implants or a full arch case, it's not very different from other prosthodontic treatment planning. The basics are still, we have to have a proper diagnosis, history taking, clinical examination, radiographic findings, scanning, and looking at everything. Once we collect that data, we share that data with our lab, or if you're doing it yourself, you put it in the computer, put things together, merge the data, and then do diagnostic. Whether you're looking at the space, diagnostic wax-ups, and then from there, you plan your surgery based on that plan. And as you're executing, you may be able to print your prosthesis or mill your prosthesis or fabricate a temp if you're loading it immediately, or once it heals, you can make a provisional prosthesis and then use this as a mock or a digital blueprint to optimize your final results. And that will all be possible if you plan the case ahead of time and then go crown down technique. If you don't have any planning, that's what happens. Like, this is an example from my residency days. Took some photos, somebody's trying to pour impressions, left it overnight. Somebody's trying to do a full mouth rehab on a hinge articulator and expecting optimal results, or mounting it something with a paperweight. So these are the things which don't work in today's day and age. We have to precisely look at everything and go from there. If we don't, we can end up with something like this. You send a case to a surgeon and you just get 4 implant placed wherever they can find a spot. In a case like this, aesthetic case, what are you going to do? So you need to place implants where they're needed prosthetically. Those days are gone that, okay, I found the bone here, let's put an implant in. It's not going to work. You cannot place implants at 45-degree and expect lab or restorative dentists to do miracles. So we have to plan prosthetically. We need to augment or graft the bone accordingly, develop the site, and go ahead and do the final outcome. So where do we start? That's always the question. If somebody walks in, whether it's a single restoration in an aesthetic zone, or we are looking at an implant in a posterior region where nobody could see, but it just need to see the overall picture. What can we do to achieve the optimal results? In my humble opinion, it's prosthetically driven implant surgery, which leads always to success. Working with the lab, get them the data, and then plan what I call it as a crown down approach leads to success. The first thing is communication. If you are working with an oral surgeon, periodontist, you're placing your implant yourself, or a prosthodontist, whoever is doing it, you need to have a communication between the providers and the lab. So you are all on the same page, and most importantly, the patient. They understand what they're looking into, what they're getting, how long does it take, what are the pros and cons, what are the timelines. To break it down, prosthetic treatment planning, surgical planning based on treatment plan, followed by implant surgery and the prosthodontic treatment. That's basically the gist of it. If you want to put it, hello? Yeah. So if you look in the upper right, there's a wax up, there's a surgical guide on the bottom. Just an example. So you plan on the top right and you execute with surgery and get an optimal result. This is like a schematic or like a dramatic presentation of what this animation shows, how you can plan an implant prosthetically. You can use a guide to place an implant and then do a predictable implant crown. So in order to do that, we have to keep in mind the key aspect of single tooth implant planning, which is not different than what we typically do in our everyday cases, which walks into our clinic. Whether it's a single crown restoration, a veneer, we do the same thing. Since implant surgery is needed in placement of implant, we need to consider the medical risk. The most important thing when a patient comes to your clinic is history, which is dental history and medical history and thorough examination. When you're looking at medical examination, you need to look at the systemic risk evaluation. I put some of the most important things. Of course, there's a long list and I don't have time in 45 minutes to cover all those things. But in short, if you're looking at implant, these are the important things. Smoking. It's not an absolute contraindication, but it's relative. But if somebody is a chain smoker, their chances are higher. Somebody who's uncontrolled diabetic, somebody has previously used or currently on bisphosphonates, they are on immunosuppressant, has cancer treatment, or they have healing issues. So of course, if you're planning to do surgery, this will interfere with that, what you're looking at. You have to look at the overall, the person has a bleeding disorder or anything like that. So anything, patient needs to be medically and surgically optimized for doing implant treatment. Healing capacity is very important, which we can get it from the medical and dental history. What is the bleeding time, clotting time, and what's if a person is on a blood thinner? It's not a contraindication, but we need to manage it with if a person is on warfarin or patient is taking new generation of blood thinners. So we need to take all those things into account. The next thing comes after a thorough examination is clinical examination. In clinical examination, what we are looking at for a single tooth are basically 4 main topics, in my opinion. Number one, inter-arch space assessment, like how much space is available at that site to place. If I'm replacing a molar at number 19 and 18 and 20 are present, do I have adequate space mesiodistally and occluso-gingivally to do a crown? And my challenge on that space is the tooth tilted? Is it straight? What am I looking at? So we need to have adequate vertical space for abutment height. So we need to now look at what is needed for at least milling these 2 millimeters of crown thickness, so minimum of 6 to 7 millimeters. But colingally, if you're doing a 19, which is a first mandibular molar, you're looking at approximately 11 millimeter of mesial distal width. Second thing is looking at what's the tissue like. Is it a thin biotype or a thick? Of course, if you have a thin, you have increased chances of recession from surgery. If you have thicker, you can get away with things. What is the condition of an existing tooth? Is the tooth is already missing or it's present? That will also determine with our next topic, which is bone width and height. If the tooth is present, so what are we planning to do? Are we planning to take the tooth out, conserve it, socket preserve it, or the tooth is already out and we know there's a ridge defect? There is a Siebert classification which talks about horizontal, vertical, and a mixture of both. So we need to evaluate what is the atrophy like. Is it buccolingual only? Is it vertically, horizontally, and how much bone is left? So all those things needs to be clinically evaluated. And then the last thing what we need to look at is the minimum distances. And I will talk about later in the presentation about that. What are the literature guidelines on those? Maintaining 1.5 millimeter of adjacent tooth helps preserve blood supply, papilla height, and that's basically, it's supported all across the literature for guidelines. And then I'll talk a little bit more about it in a few minutes. This is a classical chart from ITI treatment guide, and has been there for 20 more plus years. The aesthetic risk assessment, especially in aesthetic cases, if you're in an anterior zone, I personally still look at it. This is a beautiful image, which a chart, whatever you want to call, gives you a great idea of like what's going on. Aesthetic risk factor, let's talk about somebody is healthy and has everything perfect. It's a low risk. But somebody come with chain smoker, uncontrolled diabetic with poor oral hygiene is a high risk. Somebody is looking at the lip line in an anterior case. If you have a high lip line, of course, it's a high risk. Thin gingival biotype is a high risk. Thick is good. Rectangular teeth are better than triangular teeth. Is there what's the condition of the hygiene? If there's any infection, any apical lesions present, and if the tooth, which is neighboring tooth, is restored or not. What is the location of the soft tissue? Are there any defects? What is the alveolar bone? Is there any deficiency? If you have vertical and horizontal deficiency. So if you look at this chart, this gives you a great idea of what you are looking at. When I'm evaluating the patient, if I take a photograph or I'm clinically looking at the smile line, especially in the aesthetic zone, I keep these points in my mind what I am. The most important thing would be number 3, which is patient expectation. You want to know what patient is looking for and can you deliver what they're looking for. Sometimes patient walks in and they have anterior crowding, uneven teeth, but they want perfect teeth. So you need to set those expectations based on what you see. You cannot say I'm going to get the best results with somebody who has high expectation, triangular teeth, who is a heavy chain smoker and immunocompromised. So then you have to take, when you select a case selection involves all these factors. So when you are planning as a newbie or somebody who's starting, this is a key, or if you're even a seasoned dentist, this should be in your mind. One thing which I remember from, this is a reference from the textbooks from Wheeler we use in dental anatomy. This is historical data which was collected in 1970s. I still use this as a reference, and as I mentioned, you can see in the middle mandibular first molar is 11 or 11.5 in a mesiodistal width in an average population. For me, this gives you an idea how much space is available from the adjacent teeth to get an approximate uh, know-how if this is ideal place. Can I do a single tooth, or I have a more than a tooth space in there? And this is a key guide. The easiest example today in the digital world, I use a contralateral tooth. If a person is missing 19, I look at number 30. If it's a virgin tooth, I can just duplicate it or clone it on the other side and get the results. I can do these measurements digitally uh, on a scan or clinically with a probe, and then digitally on a radiographic data from cone beam CT. So this is also one of the chart I would recommend. If you don't have it, you can Google it, or if you have a book, you will be able to access this. This is something which also help. In this chart, they also talk about the crown length. So you get an idea about mesiodistal and the vertical. So when I was talking about the interarch space, that's what my base reference is when I'm looking at it. If I send a case to an oral surgeon and says, okay, can you place an implant at number 19 side, just put it dead in the middle. But if I'm missing 18 and I'm trying to do 19, so I will say, can you just look at distal of number 20, and from the contact, go 5.5 millimeters and place the implant dead center over there if I'm doing a freehand surgery. And that gives an idea, because you don't want to get an implant at 7 millimeters. Now you're trying to restore something. There will be a mesial cantilever. You will not be able to do ideal proportions. The next step comes is radiographic planning. So once I have done a clinical examination, then I want to collect my data. So which could be a periapical radiograph to start with, a panoramic radiograph. The two-dimensional imaging is always the baseline where we start from. But in today's day and age, the gold standard is cone beam CT. Every office has a cone beam machine in their office, or if you're working with a surgical provider, somebody has a provider or an imaging center in your area. Get a cross-sectional imaging. That's the ideal recommendation. So you can assess the bone quality, quantity, anatomic risk like inferior alveolar nerve, which is the mandibular canal, mental foramen, sinuses, nasal antrum, and see where, if you're doing a sinus lift, where is the posterior superior alveolar vessels are running, and you can see a lot of things in where your lingual vessel, lingual artery is running, or lingual foramens are there. There are a lot of things you can look in the three-dimensional which you cannot see. Of course, with any radiation, I always say a lot of principles still apply. It's not like everybody walks in, I get a CT scan before even talking to the patient about whether you can afford dental implant treatment or not. So you always need to start with your basic clinical exam, two-dimensional imaging, then cone beam as needed for those. But absolute indication, gold standard for implant treatment planning and placement is you need to have a three-dimensional image. Like for example, here you can see on the top left a cross section for planning an implant. If you look over here, there is a nerve which is generated through AI in this case, or you can draw it yourself. And then you want to see where you're placing the implant. If you have a deficiency of the bone, you can design a crown virtually in the software. This is a co-diagnostic software I'm using. And then you can go ahead and place an implant, whatever implant you write. I'm not promoting any implants, whether you are using Straumann, Dentsply, Sirona with Astra, Nobel, Biomet, 3i, Zimmer, whatever implant system you're using, they have a library. You go and place that implant and see what's going to be do. The important thing when you're deciding this, make sure if you're placing a molar implant, it has to be wide enough. You cannot put a narrow platform implant for a molar. So you don't want a mushroom on top of it. So you need to minimum look at the buccolingual width. If you don't have the width, then you need to know, okay, if I'm placing a molar, I need at least a 5 millimeter or a 4.5 millimeter implant in diameter. So I need to have a decent amount of bone. Then you look at the length. Where is the length? What is the distance from the nerve? You need to make sure you keep it safe and stay in the safe zone. Drawing a nerve is very important. If you're in the sinuses, you can do that. This patient had an all-on-X done on the top, looking for a number 30 implant. Now let's talk about prosthetically driven planning. So our goal is crown design comes first. What I did in the previous slide, we are looking at it. You need to see where the implant needs to go, what is the ideal angulation, position, and depth. Once you get that, you go ahead and figure out where you want to place an implant. And then you look at the principles of like, okay, I need an implant from the contact point at this location. And that will give you the best results. Rather than placing an implant and then figuring it out and sending it to the lab, can you do this? Anterior zone, of course, is aesthetic risk. And then we can basically need to look at overall aesthetic, lip line, where is the gingival zenith, where is the papilla present, soft tissue grafting, whether we do need a connective tissue graft. All those things needs to come in your mind when you're looking at it. And do you have enough space? Do you have any soft or hard tissue defect? In the posterior, you need to know because there will be heavy occlusion. So do you have enough occlusal table? Can you distribute the load evenly? For example, as I just mentioned, you're placing a molar implant. You don't want to place a narrow diameter implant. The other day, I had a patient presented to me, had an implant placed at a provider 7 years ago, and both at 18 and 19 site. And there were 2 crowns. They were both loose with open contact, and it's been loose for almost 6 months. She went for a cleaning. The dentist said, you need to see, and they referred me to evaluate. When I looked at it, somebody placed 2 narrow implants in a molar site rather than grafting and augmenting the site and making it wider. They just placed 2 implants, charged the patient for 2 implants and 2 crowns, and they both lose with bone loss. The ideal treatment at that point was to augment the bone, optimize the site, and then place 1 single implant, which could have been a 4.5 to 5 millimeters, and get a proper crown. So those are the priorities which you need to see. Another thing is, where do you want your emergence profile? Where do you want your access hole? So whether you're doing cement or screw retain. Since I've been practicing for close to 25 years, so of course I started my career in the world of plaster. So this is, if you still are one of those practitioners who are using alginates and VPS and doing freehand and talking the lab, most of the labs are digital. This is the old school way of doing it. You basically make an impression, pour it up, do a wax up, do a suck down, and draw a line, put the hole in the middle, and give it to the surgeon and place an implant. This is what I was teaching students, I would say 15, 20 years ago, how to precisely place an implant in the dead center, so we can avoid any injury to the roots or anything, just and get the optimal results if you're looking for. In today's day and age, we can do a digital wax up. We can do it either on a sophisticated software like 3Shapes, ExoCAD, or a native scanning software, which is if you're using any scanners, they come with some kind of a software, and you can basically put tooth in there, or you can digitally design it on a computer and you can see it. Now let's come to the surgical planning. Now we have taken a CT scan, we put the crown on top. Now we need to know where the implant needs to go. So implant position typically needs to be 2 to 3 millimeter apical to the planned free gingival margin for proper emergence profile, because you don't want to place an implant which is sticking out at the gum level. So it has to be at the bone level. You may have to submerge it sometime, depending on, you need to see the adjacent CEJ, height of contours, and see where you need to place the implant. If you're doing guided surgery, it is very crucial that you need to know the exact location. You need room for the guide, its sleeve to go in. So of course you need to plan accordingly. Guided surgery helps you precisely place an implant in a site, but you need to make sure that it's optimally done in the software, and then you are following the guided surgery protocol. Proper irrigation is important. It will give you a precise osteotomy and implant placement, and that gives you the most predictable option. Bone grafting decisions are very important because a lot of questions will come to your mind. Is the tooth present? Am I taking it out and placing an implant? What is the condition of the socket? Are the walls intact? Is there a periapical lesion? Are we doing an early placement after soft tissue healing in 3 to 6 weeks? Or we are augmenting the bone, or we are socket preserving and waiting for everything to heal and come for a delayed placement. The biological consideration for implant treatment is, if you have a site like this, you walk in, the tooth was taken out, you don't have any bone, of course you cannot do an immediate implant over here. you have to go and augment the bone, graft the site, come back, revisit, and there are a lot of challenges involved. So you have to always look at it. If there's any infection, you need to curate it out, make it very clean, because if you leave it, you can end up with a residual cyst or a residual infection and a defect over there, which will not be optimal for your long-term implant placement and restoration. Site development is another topic. It's a topic on its own. Like you can give a lecture on this topic for half day or a full day. I will give you a brief introduction about it. You can do bone grafting. Bone grafting could be like a socket preservation. You take the tooth out and put some kind of bone in there. You can do a guided bone generation. If you need to do a vertically or buccally augment the site, as you can looking at it, this is socket preservation, guided bone regeneration. You can put corticocancellous bone. You can put a block graft. If you're looking in a sinus, you can do a sinus lift. It could be a direct or it could be a lateral window. You can do distraction osteogenesis to expand or vertically augment or vertically basically correct the bone. You may look at the soft tissue is very thin or you have gingival recession. You may need connective tissue grafting or a free gingival grafting. You may see the tooth, the bone is not there. You decide to orthodontically extrude the tooth, which is failing, but you can bring it down to correct it. So it depends what you want to do for site development, but you need to identify these cases prior at the planning phase. Interdental papillus, classic study from Tarnow, talk about contact point. So approximately, we are looking at in millimeters, 6 millimeters to 5 millimeters in an ideal contact point from the bone and the crust. That was measured. So that's it's a pretty common thing. We know this comes from Dennis Tarnow back in '92. In this slide, I will try to put a lot of things together. So a lot of time when I'm giving this lecture, dentists will ask, okay, what about spacing? What do we do? We talked about tooth spacing. Let's talk about implant spacing, like a surgical consideration right now. We already talked about mesiodistal, occlusal, gingival dimensions. If you're talking about a case, for example, here we are looking at 28, 29, 30, and 31s are missing. So where do we place an implant? Based on scientific literature, this is something you need to know. If you are a surgeon who's trying to place implants, I'm sure you already know. If you're a new dentist who's trying to, these are the key things which you need to keep in mind. These are the minimums and these are some guidelines. So that's what I like to follow, what I have learned in my residencies and based on the literature. So if you're placing an implant at number 30 site, and this is just animation just to give you an idea, you're looking at a 1.5 millimeter distance from the adjacent tooth. So remember that tooth to implant distance, 1.5. Dennis Tarnow talked about it. Ideally, buccolingual width should be minimum of 1 millimeter. Excuse me. Ideally, it needs to be 2 millimeters. More buccal bone you have, that means you have more, or lingual bone you have, that means more success. This is an ideal environment, but you cannot place an implant with no bone on the buccal or the lingual. I would say 1 to 2 is very important. Let's talk about the next topic. What about if I'm placing 2 implants next to? It's still a single implant restoration if I'm doing 30 and 31. The Dennis Tarnow again says about 3 millimeter. So inter-implant distance, 3 millimeter. Tooth to implant, 1.5. Buccolingually, minimum 1, ideally 2 millimeters. Then another thing is implant distance from the nerve. I will talk to you guys about that in my next slide. So this is on the left side. We see a cross section on a CT scan. We place an implant. This is an inferior mandibular canal, which is visible over there. On this side, this is an animation of number 18. Then 19 is an implant 20. This is the mental foramen. The nerve is marked over there. The ideal guideline, if you're looking at it, 2 to 3 millimeters. Some lot of software will give you that flag and then let you know where it needs to be. But ideally, safe zone is 2 to 3 millimeter. If you're doing it guided, it could be off by a millimeter. You always have to remember, some experienced surgeons will say, Yeah, I like to be within 1 millimeter. If you're doing any guided surgery, literature says there is always a discrepancy of a millimeter. So you have to keep that in mind. So my philosophy based on that is keep 2 millimeters and keep more wiggle room for yourself, because you don't want to be, if some error happen in planning and merging the IOS scan with your CT scan from the lab, or in printing, or in you place the guide, it was slightly down, something happened, keep yourself a room and always do minimum of 2 millimeters. Your implant osteotomy burrs, they have a plus, almost +1 correction. Some have zero point 0.5, some have zero point 0.1. So you have to keep that in mind, that you always have a little more placement risk. So you have to keep that in mind. 2 to 3, in my opinion, again. So this chart on the bottom gives you all the details which I talk about, and that's a good option for you. So then another thing which comes from Dan Boozer in 2004, he talked about interproximal bone height and facial bone. The more facial bone you have, it's much better for you. Interproximal bone, if you have it, it will preserve the papilla, because that is needed for the papilla to come back. If you don't have that, it will be very difficult for you to get the papilla, because bone dictates where the papilla needs to be. If you're talking about an interior implant, again, Boozer mentioned about comfort and non-comfort zones. If you're looking at it, you need to make sure you're placing an implant from the adjacent CEJ at a distance where it's not too much submerged or too much coronally placed. Implant, you are looking at an axial hole in an anterior coming from a lingual eye, in my mind. Just think about root canal, where the axis hole should be for a root canal. That's where you want your implant to come out. Ideally, that's what you need to look for. That's how you need to design it. If you don't have the bone and you cannot augment it, we can always use ASC, which is an angle screw channel. But ideally, if you can avoid it, that's what differentiate between a good implant placement and, like, okay, where the bone is, I can place an implant. Upright the implant as much as possible to achieve. Sometimes it's not possible because the labial bone is tilted 10 to 40 degrees, and you cannot upright an implant, otherwise you will end up with an apical fenestration. So it is crucial to do that. Important question, where will the implant go, when to place an implant? We already covered this. Just to summarize one more time before we move on to the cases and to respect the time for the webinar. Prosthetically driven, we need to know where the final tooth position would be. Clinically, the site where you're placing the implant, buccolingual, mesiodistal with apical and coronal depth, angulation, and your cone beam, wax up, restoration. This is all will decide where your positioning would be. Timing depends on if there's any infection present that we cannot do immediate. Bone quality is good or bad, and what is the primary stability. If you have no infection, you immediately place an implant, and the torque is somewhere between 35 to 70 Newton centimeter. You can load the same day. You can basically place the implant, and if you think you can load it, you can put the crown the same day. Immediate implants are considered same day. Early is 4 to 8 week. Delay in convention 8 to 16 week. You can stage the implant to do grafting, come back and heal depending on the grafting material. You may have to wait 4 to 6 months. That will decide what type of material you're using. The other factors are restorative factors, fixation choices. Like I personally use screw mentable to avoid any cement, screw retrievable implants. Crowns are my preference, but in some cases, if you cannot, then you will be using cement retain. You can't, basically, if it's in the aesthetic zone, you cannot have an access hole coming out from the facial. If it's in the posterior, and if it's coming from the lingual or the buccal, you cannot put a filling over there. So of course, restoration will decide what you need to do. Ideally, my aim is always to do screw retain or screw mentables. Emergent profile, if you're doing it in the anterior region, you have to profile your tissue. You have to put provisionals in there, optimize the tissue, and basically you have to get a custom profile of your tissue, and you have to do that. This is an analog, and I'm customizing the site for an implant. So you need to make sure it looks like a CEJ and crown on a natural tooth, the way it looks on the root. So you need to give that. You cannot just put a what you call as like the pre-made or prefabricated healing abutment and just do it. You can customize at the time of surgery or do it soft tissue profiling after. Key consideration, what we talked about, this is a summary of it. Clinical exam, radiographic planning, medical history, prosthetic planning, surgical planning, and restorative. These are the key points. If I have to summarize everything in the visits, this is what comes to my mind. Number one step, diagnostic assessment, treatment planning. Step one, you see the patient, discuss expectation, history examination. Step two, your treatment plan, collect the data, IOS scan, CBCT, VPS impression, whatever you're doing. Then you come to a consultation with the patient, have a consent sign. If you are doing the surgery, you will do it all yourself. If you're sending it to a provider, they will take care of it. You fabricate a surgical guide. Next step, surgery. You have looked at the surgical issues, what could be there, any difficulties, any problems. Stage one would be implant surgery. Step two would be post-operative review, suture removal. If it's a stage one or stage two, based on that, you will decide. Prosthetic procedures. Step one would be impression taking, impression making, whatever you want to call it. Fabrication of your final prosthesis and insertion of your final prosthesis. You may include a provisional in step if you're immediately loading. Aftercare and maintenance, it's very simple. You will do a follow-up and then you put in a regular maintenance. For me, for a simple implant restorations, I like to do a periapical radiograph or vertical bite wings every 12 months to see where the bone levels are and to evaluate. In aesthetic site, you basically need to know that you have to look at the diagnosis and the risk assessment, which I show you the ITI treatment guide for single tooth restorations, aesthetic planning, wound healing, diagnostic wax-ups, site development if needed, implant surgery, provisional prosthesis, and final prosthesis. We'll go through some case reviews in next 5 to 10 minutes, and then we'll open it for questions. So as a patient in the anterior zone, this was, my wife is a periodontist, so she basically referred to her. She basically planned it, placed an implant at number 8 site. You can see some deficiency over there. Needed some implant placement and some grafting. That was achieved at the time of surgery. That was a plan. Placed the biologics, closed everything. Decided not to load because of obvious reasons. Let it heal. This is a provision for that restoration. You can see the access hole coming from a lingual. Another patient presented, had number 13, which fractured with limited ferrule. Discussed option for saving the tooth with cast post and course versus implant. Patient did not want to go with root canal, crown lengthening, and he wanted to do this. Basically, looking at the tooth, can we do an immediate implant? Decided that the bone looks sufficient, the tooth has no infection in the cross section over there. This is an IOS scan overlaying on it. You can see it, and then we design a surgical guide to see how it's going to be. So if you can place an implant and achieve stability, the plan would be to place the implant immediately, but do not load it because of the obvious reason. We have implant in the native bone, but we may not be able to load it because of the risk of occlusal loading, especially in this is a guide on the right. This is again co-diagnostic software. This is pictures on the left, basically after healing, a scan body in place, scan body, and this is the final restoration. You can see here the access hole is coming from dead center. Everything looks good. It looks exactly the same proportions as compared to the adjacent teeth. Another case, this time a different software. This is a Remexis freehand surgery, and you're looking at a single implant placement at tooth number 4 site. The site already was extracted, healed, and we are looking at the sinuses. Look at that. Looks like enough room to place an implant without doing any sinus augmentation. Implant was placed. Then custom abutment was designed in this case, and you can see access hole coming from the occlusal. Patient came and said, listen, I want gold crown. So we did gold crown. This was SLM, and then custom abutment with the proper profile was fabricated. This is an example of a gold crown on number 4 site. this is a nice case where, as I was mentioning about the need of cone beam, we are using DTX, Nobel Clinician, which is the old name for it, software for evaluation. Place the implant at number 30 side. Looking at it, if you see here, we can see the IAN over here. We have the model, everything. We are planning a guide. And here, if we don't take into account, you can easily perforate on the lingual. So this implant placement was very crucial. Guided placement was amazing, key in this particular one, because if you would have looked at the two-dimensional X-ray, you would have placed an implant, because this will look like IAN is like, or mandibular canal is like 15 millimeters away from there. And then you can place an implant right over there and you will be perforating the lingual. So this way you can prevent that and you can just plan it 100% perfectly, and you can go ahead and execute properly. In this case, you will place a shorter implant to achieve optimal result. Immediate extraction, another case, patient came with basically a failing root canal treated tooth. The buccal bones and lingual bone appears to be intact. As you notice, we are placing an implant and submerging it because this is an immediate. We are expecting some bone remodeling. Overlay the models and the guide, everything. So this is a cross-section buccolingual view. You can see the implant. This is where the guide sleeve would be. We have a plan for the crown. Likely chances we may or may not be able to load. So this is basically a tooth pre-op. You can see there's a rotation, so we decide to do a crown. Very challenging case because the patient did not want to extract it, did not want to do any other restorations, which ideally I would have preferred doing a crown on the anterior teeth or veneers to fix it, but he said, I just want this fixed. And if you want to fix it for the sake of implant, just do a crown over there. So little compromise decision, but extracted the tooth, guide used to immediately place an implant. The torque was not enough to load it, but good to place. Let it heal, closed it, sutured, put a temporary, just use the same tooth and bond it over there as a temporary to maintain the site. And this patient came back. This is the same day of delivery. We ended up crowning it. The papilla will grow. It takes them somewhere between, I would say, around 6 to 12 months to get the papilla back. You can see we would have achieved better results if you would have done some crown lengthening, some veneers, but patient just wanted 2 teeth. So this is a result for that. This is the sequential radiographs here. Tooth present with root canal, failing crown. Tooth was extracted, immediate implant place, grafted, temporary, the same crown. We just put it as a temporary over there, or the tooth as a temporary material impression taken. And that's pre and post-op. Almost time to wrap it up. So take home message. Simple implant restoration is an ideal replacement option. This is a gold standard for and the first ideal option for tooth replacement for a missing tooth. Fix dental prosthesis, also known as a bridge, is always comes second because you are biologically cutting tissue. So always keep in mind. An in-depth review of medical and dental history is very important. Sorry for the typo. Is key to successful outcome. Precise prosthetically driven treatment planning that keeps both surgical and prosthetic principle in mind is very essential in treatment. Immediate placement and loading of implant is very predictable. A lot of cases you can take the tooth out, place an implant. Having said that, mind that you have no infection present and you have socket present to place an implant. Ideally, guided implant placement is an excellent option and should be utilized whenever it's appropriate or possible to do it, because it will give you the best result. Proper communication with the lab is key to create an optimal plan. If you provide the data to the lab, they can give you the best treatment plan. You can use the guided surgery software and get the best results what you can. Teamwork is very important. You need a good dental lab. If you are working with the surgeon, you need to have a good surgical team, and communication is the key over there with your surgeon, your periodontist, or whoever specialist, or if you're doing it yourself, your team, you need to do that, and that will give you the predictable outcome.